Right, good evening, ladies and gentlemen, motivators, party people. Welcome to your part one of your Mod 4 review session, which is basically the first 5 chapters. And then tomorrow is going to be the last 4 chapters. I'm going to try to keep this in an hour to an hour and a half-ish review. This is not a reteach, it's just key points. The only longest topic on here is cardiac emergency, but it shouldn't be a hard teach since you already learned it in class. Okay, so somebody's microphone is not muted, so please mute your microphone. 954, this is your last warning. I'm about to force mute you if you don't mute your mic. All right, you're going to be muted. Mute audio. There we go. So, starting with chapter 16. Chapter 16 is basically just about all the drugs that you have learned. There are 7 interventions, right? 7 interventions that we talked about on this specific chapter, right? So those 7 right there are the only ones that you are required to either assist or administer to your patients. Know which ones you carry at the back of your ambulance, and as well as know which one are you going to assist with your patients, okay? For those of you that were with Bravo, right, remember that ribbon? I'll make sure I'll send that to you, to everybody via email, the ribbon method to identify. There we go. Somebody's showing it in the camera right now. I don't know if you guys see each other's cameras, but the ribbon method helps you identify which one is carried at the back of the ambulance. So let's start with the medications that are carried at the back of the ambulance, or the ones that you can just carry. Most of the time, you can administer this because it's offline. It's a standing order. Okay, so pharmacology, as we all know, is the study of drugs and their characteristics. Okay, so the first drug and the medications that's in your ambulance is aspirin. Okay, aspirin is a medication that is utilized not for pain, but for clotting. Right, so it's an anti-clotting because it's a blood thinner. So even though aspirin is used over the counter for pain purposes, it's used for blood thinners on this one, specifically for patients that are experiencing chest pain that do not have a nitroglycerin prescribed to them, or if the nitroglycerin that they take did not work. So that's your first one. The second one is oral glucose. Oral glucose is another medication that we utilize for our patients that are experiencing diabetic emergencies, and you've already learned that whether they are hyperglycemic or hypoglycemic, we treat those the same way using the oral glucose. Okay. We also have oxygen. Oxygen is very common. We do this during the primary. This is the time during the breathing portion, depending on the patient's rate and quality and O2 saturation. We'll determine what type of O2 therapy we're going to give our patient. Is it going to be NRB, nasal cannula, BVM, FROP-BD, okay? And then the last one, activated charcoal, is right in the middle because it's not always carried at the back of the ambulance. It can also be sometimes in the household of the patient already, but for discussion purposes, we're going to consider it as something that's carried at the back of your ambulance, right? This is basically for those individuals that overdose on drugs, right? During your poison overdose lecture, you learned the main use of this activated charcoal. Now, all those medications that I mentioned, aspirin, activated charcoal, oral glucose, and oxygen, all those 4 right there, you have to check their expiration dates, all of them. You can't, besides oxygen, but you have to check all their expiration dates because you do not want to give an expired medication to patients. When it comes to skills, tomorrow when you guys practice your skills, one of the things that we're probably going to be hard on you guys is not checking the expiration dates of your medications, and that's a big no-no right there. Okay. So any questions with those medications that you carry at the back of your ambulance? Thumbs up if you guys are good. Everybody good with that? Perfect. Let's move on. Now let's move on to the prescribed medications. With this one, for prescribed medications, we are basically focusing on assisting. That is your magic word for this prescribed medications, assisting. It's not, you don't administer it yourself. So the acronym that came up with this is the Big Ben medications, BEN, right? Bronchodilator inhalers, epinephrine, and your nitroglycerin. So let's start with the bronchodilator inhaler. Okay, this is specifically for your patients that are experiencing respiratory emergencies, such as asthma, If your mic is not muted, please mute your microphone because we can hear you moving around and I cannot track who's doing that. So mute your mics, whoever you are. Okay. So the bronchodilator inhaler, like I said, it is for your respiratory emergencies, such as patients, commonly patients that have asthma. Okay? And then you have your nitroglycerin. Nitroglycerin is for patients that are experiencing chest pain. It basically dilates the blood vessels. We cannot give contraindication to this. It's already mentioned early on in this chapter. You cannot give this to patients that took what? Patients that took what? So we're not going to give nitroglycerin if they already took what type of medication? Very good. ED, erectile dysfunction medication such as Viagra, Cialis. Okay. We're also not going to give it to patients that are already hypotensive or those that have systolic blood pressure that is less than 90. Okay. And the maximum dose is 3. And then the last prescribed medication is epinephrine. Epinephrine is used for patients that are experiencing anaphylaxis. Remember, it's anaphylaxis, not mild allergic reaction. As we're going to cover tomorrow when we talk about the allergic reaction. Okay, so those are your prescribed medications. Any questions about those 3 specific medications? Thumbs up if you guys are good. Okay, let's move on to the other drugs that you might administer. The main one that they talked about here is naloxone. Okay, naloxone is basically a medication that reverses the effect of a narcotic. Okay, so those individuals that overdoses in narcotics, they tend to go into respiratory arrest or respiratory failure. Most of the time, they just cease breathing and then they pass out. So in order to reverse this effect, naloxone was created and generated to reverse this. One thing that we do attach to naloxone is an atomizer. Atomizer is basically a device that we attach to basically make it a lot more finer, like the droplets, make it more microscopic, that it'll be easier absorbed into the body. Okay, so that is for your naloxone. And then this chapter also talked about a bunch of key terms. Okay, so for example, it talked about the generic, right? Generic name, brand name, and chemical name. So know those differences of what's the difference between specifically generic and trade name, right? So Tylenol is a brand name, right? And then the generic name of Tylenol is acetaminophen. Okay, and there's a chemical name for it that is pretty long, and sometimes you can't even pronounce it. Okay. And then we also have terms such as indications and contraindications. Indications is anything, any scenario where you can give. It's appropriate to give this medication. For example, nitroglycerin, indications for it. Patient is prescribed nitro. Patient has history of chest pain or is experiencing chest pain or cardiac emergency. Patient has to have a systolic blood pressure of 90. All those are indications where I can give nitroglycerin. The opposite of that is contraindication, where basically you cannot give this medication under any circumstance. For example, contraindication for nitroglycerin, systolic blood pressure of less than 90, if they took erectile dysfunction medications already. Okay, and then we have the terms side effect and untoward effect. The way that they explain this is side effect, when they were creating the drug, they expected this. This is something that they've already seen. It was going to happen, right? And it's commonly, you're not going to be surprised that, the patient is going to have some headaches when they start taking nitroglycerin, because nitroglycerin is a vasodilator. And when your blood vessels open up, your blood pressure goes down. So you experience that headache or dizziness. So it's a side effect. It is expected. The untoward effect is a side effect of the medication that we did not expect this happening. And usually it's a negative effect, right? It's an adverse effect of a medication that we did not expect, right? So simply put, side effect, we already kind of expected this. It was on the label. It was disclosed. Untoward effect, we didn't expect this. Is that clear, everybody? Okay. Then we have parenteral, okay, or parenteral and enteral. Parenteral just basically means any medication that does not use the gastrointestinal route. So anything that we don't swallow, okay, is called the parenteral. So usually these are the ones that we inject or the ones that are given through IV or intravenous. And then enteral is anything that we swallow, such as the pills that you take. Okay, so those are the main terms that you have to know specifically for the pharmacology chapter. Okay. Any questions with those terms? Right, let's move on to the authorizations. There's two ways to give authorizations. You already learned this as early as Mod 1, right? There's offline medical direction, basically standing orders. Most of the time, your medications that you carry at the back of your ambulance are standing orders. For skills purposes, whether the medication is prescribed or not, you have to call medical direction, okay, for permission to intervene and transport, just as a tip for every one of you that's going to take skills tomorrow, okay? Then next is we have online medical direction. Online medical direction, we have to call, right? We have to ask permission because as EMTs, we really cannot diagnose. So we have to verify first with a physician, hey, this is what I'm seeing. Do you think it's appropriate to give this type of medication? So that's the difference between offline and online. Then we also have 5 rights. The acronym for the 5 rights is PRTMD, right? P, Papa, Romeo, Tango, Mike, Delta. Okay, remember that. PRTMD, right patient, right route, right time, right medication, right dose. Those are the 5 rights that you have to check specifically for prescribed medications. HM1, can I do 5 rights for the medications that are at the back of the ambulance? Yes, by all means, do the 5 rights. Okay, I'd rather you do the 5 rights for both ambulance medications and prescribed medications than forget those 5 rights all in all. So please make sure you always check 5 rights and expirations, okay? And then we also have the different routes of medication, okay? Different routes of medication, we have oral, okay? Oral medication that basically you swallow the pill. And then we have sublingual. Sublingual medications are the ones that are put under the tongue, such as nitroglycerin. Till what time is this still, Caleb, or whoever you are? It's till I'm done. Then we have inhaled medications. Inhaled medications is basically things that such as your the oxygen, right? Oxygen is a drug, you inhale that. Then we have intranasal, such as the naloxone. Naloxone is something that you administer intranasal through the nose. Then you have intravenous through the vein. As EMTs, can we administer medications intravenously? No, right? You cannot. That's a big no-no right there. Okay. And then intramuscular, an example of an intramuscular medication is epinephrine. Then we have subcutaneous. Subcutaneous is basically on the fat portion of your underneath your skin, right? The subcutaneous layer. That's when they squeeze the flabby part of your arm and inject a medication right there. And then we have intraosseous, basically via the bone. That's commonly utilized by advanced life support, so AEMTs and paramedics. And then we have the endotracheal, basically through the trachea, when they have an endotracheal tube or an ET tube inserted down their throats. And again, this is only for ALS, but there are some medications that are administered through that route as well. Okay, so any questions with the 5 rights, authorizations, and routes of administration? Everybody good? Right, let's move on to pharmacodynamics. Pharmacodynamics is the study of the effects of the medications of the body. Know the difference between pharmacodynamics and pharmacology. Most students confuse these 2 terms, so make sure that you guys are not understanding the main difference between pharmacodynamics and pharmacology. And for reassessment and documentation, every time you give a medication, reassess after how many minutes? Interventions are always after how many minutes? 2. Very good. 2 minutes. After 2 minutes, reassess your interventions. It's simply put, ma'am, how are you feeling? Sir, how are you feeling? Are you feeling a lot better? That's basically your reassessment of your interventions. Okay. Then we have page 455 for those of you that are on your textbook. Okay, you don't need to memorize those medications, please. Don't. If you're creating the flashcards for these meds, stop right now. Don't even bother making those flashcards. But I do want you to know what those terms mean. For example, if I tell you analgesics, I want you to know that that's basically for pain. Okay? If it's antidysrhythmic, I want you to know that that's for heart rhythm disorders. Anticonvulsants is for seizures. Antihypertensive is for high blood pressure. Bronchodilators is for the respiratory system. Anti-diabetic agents for those individuals that have hyperglycemia. And antidepressants are for those individuals that have psychological and emotional stress, right? So No need to memorize specifically what medications. In nursing, trust me, when you guys get to nursing, you will have a full-blown chapter where you have to memorize all these medications. So for EMT, you don't have to do that for now. Just know the general classifications of it. And then the last part of this specific chapter, assisting in IV therapy. The main thing about this specific one, I'm not going to go too in depth about it, but the main thing as our job as EMTs, we assist. Okay, we cannot, as EMTs, we cannot start IVs. Okay, we prepare them the intravenous drugs or the normal saline or whatever what we're going to administer intravenously. But as per your text and as per NREMT guidelines, only advanced EMTs and paramedics are allowed to do IV therapy. However, as medtechs and as corpsmen, you can and you will, because in nursing, you guys are going to start doing this, the IV therapy. You guys are going to be poking each other with catheters in each other's veins. So you guys are mentally preparing yourselves for that specific and highlighted event in the schoolhouse. Okay, so that's basically chapter 16. Any questions for chapter 16? Any clarifications that I can clarify for you guys? Nothing? Everybody good? Wonderful. Let's move on to chapter 17, respiratory emergencies. Okay, so for the respiratory emergencies, it gave you the first few pages. You should already know about this. It's basically a quick review of Mod 2, right? If you notice, the first few pages of this chapter talked about Mod 2 all over again. So if at this point, if you still don't know what adequate and inadequate is, let me know now and I will start your processing your paperwork back to another class that's still in Mod 2. Right? At this point, you need to know what is adequate, what is inadequate. The rate, rhythm, and quality, right? Those are the three things that we do check when we're checking for breathing. Remember, rate and rhythm are not the ultimate determining factor, okay, for the patient's inadequacy or adequate breathing, okay? Because what do you mean by that? For example, after a run, okay, your rate is probably going to be way up. You're probably going to be breathing at 24, 26 breaths per minute. Your rhythm is probably going to be a little bit irregular because you're breathing way too fast. It's not your normal breathing. However, it doesn't mean that you're inadequate. Okay, it doesn't mean that you cannot breathe properly, but there's still adequate breathing taking place. It's just that your rate is a little bit high and your rhythm is a little bit irregular. So the rate and rhythm is not the ultimate determining factor for adequacy. Quality, however, this will give you a more indication of what type of respiration is my patient having. Okay, so when I say shallow, when I say labored, these are probably things that will trigger something in your head. It's like, whoa, labored breathing, okay, at 30 breaths per minute plus labored. Okay, that's probably time to give my patient a BVI. Right? So those are the three factors that you have to consider when it comes to inadequate and adequate breathing. Is that clear, everybody? Okay. And if you want clarification on that one, page 467, on the second bullet, it says right there, the rhythm of inadequate breathing may be irregular. However, rhythm is not an absolute indicator of adequate or inadequate breathing. Okay. And then you should also know on page 468 that pediatric note, it's been showing up since Mod 1, Mod 2, it showed up again in Mod 3. Guess what? It's in Mod 4 again, that pediatric note, the difference between a pediatric and an adult airway. You should be at this point, hold on a second, guys. I'm getting a phone call. I'll pause this real quick.
La 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 la. La 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 la. La 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 la.
All right, please start muting your mics. Thank you, William, for reminding everybody that it is recording. So for those of you that are disrespectful and doesn't give a fuck, you just ruined the recording for everybody else. So thank you for being assholes. All right, moving on. All right, moving on. So going back to page 468, that pediatric notes section. Remember, I'm not going to go over that. You should already know how is it what's the main difference between a child and adult's airway in terms of tongue, trachea, chest, the cricoid cartilage, and everything else. Okay. And then that specific table in 469, okay, that is what you're going to give your patient. If you guys remember from Mod 2, there's that specific chart. And when we covered this in Mod 2 specifically, we talked about the difference between adequate and inadequate, right? The respiratory distress, progressing to respiratory failure, to respiratory arrest. Know when's the right time to give a non-rebreather, a nasal cannula, and a ventilation, because in your skills tomorrow, we expect you to know that during your primary assessment, what you need to do in terms of providing oxygen therapy in your patient in your primary assessment, okay? It also talks about this, the very beginning chapters talks about if the patient's airway is not patent, what are the 3 things that we need to do when their airway is not patent? What do we do? There's 3 magical things that we have to do on a patient's airway. What are those 3 things? Very good. Open, clear, and secure. Very good. Open the airway using head tilt, chin lift, jaw thrust. Clear the airway by suctioning no more than 10 to 15 seconds. Okay, and then secure the airway using an OPA or an NPA depending on what the patient tolerates. Okay, so those are basically your basic interventions or basic assessments for your patients when it comes to airway. Okay, then we have the breathing difficulty. Now it goes into details about what type of emergency you're going to be seeing with these type of patients. Well, it starts with breathing difficulty. This is basically a patient saying, I'm having a hard time breathing. I can't catch my breath. It feels heavy when I'm taking in air. Okay, so this is there's nothing special that you ask different when it comes to these emergencies. All of your patients will be asked the same OPQRST, the same ample, and the only difference is probably going to be your clarifying questions. And I've gotten a lot of emails from a lot of you about, H1, I'm so confused about the clarifying questions. What clarifying question will I ask? Well, it really depends, but the most generic one that you can ask is a clarifying question about what have they done so far to help them out. Because this question right here allows you to identify how many doses have they already given to themselves, right? Because the bronchodilator inhalers has a maximum of 3 doses. Nitroglycerin has a maximum of 3 doses, and you won't find that out if you don't clarify to your patient about the medication that they're currently taking, right? So OPQRST, onset, provocation, quality, radiation, severity, and time. Ask those questions to somebody who's having breathing difficulty, as well as the ample. On page 472 and 473, full of valuable information about what does an inadequate patient look like, right? Same thing in Mod 2, but you have cyanosis, flaring nostrils, okay, and retractions, specifically for pediatric patients, right? Then you also have these sounds on page 473. Wheezes are high-pitched sounds during expiration. Stridor is a high-pitched sound during inspiration. So know those differences right there, okay? Wheezing and stridor are both high-pitched. The difference is wheezing is when you're exhaling, okay, exhale. Stridor is when you're inhaling, okay? So make sure you know those differences when it comes to sounds. And then crackles is any type of bubbling. That means that there's probably fluid inside the lungs. And then rhonchi is just a lower pitched sound because that sounds like snoring or rattling because of possible patients that have pneumonia or bronchitis. You're probably going to hear the rhonchi sounds, okay? And we assess the breathing We assess the breathing through mid-clavicular, mid-clavicular, mid-axillary, mid-axillary. That's how we're going to assess for breathing. This is actually, if your patient has a respiratory emergency, one of the focused physical exams that you have to do is mid-clavicular, mid-clavicular, mid-axillary, mid-axillary. Okay? So any questions so far with those assessments? Pretty straightforward, yes? Okay. Like I said, it's just those few pages right there. That's just a quick review again of Mod 2, because airway is a very important topic. That's why your first emergency is the respiratory emergencies. Then this specific chapter also went into detail about CPAP, right? The continuous positive airway pressure. CPAP is a new pre-hospital intervention that is being introduced into the EMS system. We can utilize the CPAP when the patient is obviously having difficulties breathing, but there's some indications and contraindications for this one. For example, indications for these type of patients that are experiencing pulmonary edema, basically fluid in the lungs, drowning, or any type of fluid in the alveoli, because CPAP will push the fluids out of the alveoli. Asthma and COPD can also be, you can also use this, the CPAP to these types of patients, right? Contraindications for this one, this is all in page 475, right? Contraindications for this, when patient doesn't have spontaneous respiratory breathing, that means they cannot follow simple instructions. Because remember, CPAP is it's giving continuous air, right? Continuous positive air into their lungs. So if you give them continuous air and they can't follow simple instructions, that can possibly be very dangerous for your patients. That's why it's advised that they kind of have to be able to follow directions. Side effects of this is it drops the BP, because too much positive pressure into the respiratory system can decrease the negative pressure, which is responsible for refueling the blood in the left ventricle. It also causes, there's a possibility for air to get into the stomach, so gastric distension can be a side effect of this one as well as drying of the corneas, because what happens is when you put the CPAP, if you look at the picture on page 476, if it's not properly sealed, the oxygen can leak and then dry the corneas. Okay? So that's basically for the CPAP machine. If the patient starts declining, for example, you gave CPAP and they started having a hard time breathing, and their respiration is continuing to decline, you will remove the CPAP and possibly start with assisted ventilations, okay? So just be mindful of that one as well. That's why on page 476, you see the patient, they started with CPAP, and then all of a sudden the patient started declining, and then they had to switch using a BVL. Any questions for that class? Everybody good? Okay, now let's move on to the different respiratory conditions, right? So first off, we have COPD. Okay, COPD is a chronic obstructive pulmonary disease. This is just basically an umbrella term, okay? An umbrella term for the different types of possible.
Let me FaceTime you when I get to my room, okay? Because we're doing this live chat and they can't hear.
Whoever's talking, you need to mute your microphone, please. Mute your mic, everybody can hear you. Jesus. Okay, so COPD, like I said, is an umbrella term for such as for emphysema, right, or chronic bronchitis. Those are examples of chronic obstructive. So chronic means it's been going on for a while. Obstructive means that there is an obstruction in the pulmonary system and it is some sort of disease. Okay, so for this type of patients, what can we do as EMTs? Well, if they have COPD and they don't have a prescribed bronchodilator inhaler, what type of intervention can we provide these patients if they're having a hard time breathing? What's the only intervention that we can do for them? Anybody? What is it? If they don't have a bronchodilator inhaler and they have COPD. Very good. O2, right? O2 and transport your patient. That's the only thing that we're going to be able to do for our patients, okay? And then we have asthma. Asthma is basically when the bronchial muscles in the bronchioles are spasming or constricting. Okay, so this is when most of the time when patients have asthma, they're prescribed a bronchodilator inhaler. So that's the one that we're going to be utilizing for that one to open up their bronchioles, right, to prevent that bronchospasm. Now we also have pulmonary edema. Pulmonary edema is when the patient has congestive heart failure, okay? Because remember, the congestive heart failure, the left ventricle is failing miserably. So what happens is the fluid is backing up. Well, if you track the fluid that's backing up, the fluid can back up all the way up to the lungs. So when you auscultate, you might hear those crackling sounds in the lungs or bubbling sounds in the lungs, right? And that's a sign that there's possibly pulmonary edema. Other signs of pulmonary edema is also edema in the feet, also known as pedal edema or sacral edema, fluids at the back. So wherever there's gravity, the fluid follows, okay? So that's why you see patients that have swollen feet, and they're probably also going to be complaining of that drowning feeling and overnight weight gain. Those are obvious signs of pulmonary edema. Main treatment for this patient, possibly high O2, and transport your patient. Okay, because pulmonary edema, there's nothing really that we can do for our patients that have pulmonary edema in terms of pre-hospital care setting. When they get to the hospital, then they're going to get more advanced care for that one. Okay. Then we have pneumonia. Pneumonia is infection of the lungs because of a bacteria, virus, or fungi. Okay, a pneumonia most of the time accompanies fever and chills. Sometimes they will have a cough associated with it. Okay. When a patient has pneumonia, if it's not contraindicated, it is preferred that you use CPAP. Why CPAP HM1? Well, remember, pneumonia weakens. What happens with pneumonia is there's possibility that there could possibly build up of fluids in the alveoli. So what you want to do is with the CPAP, right? With the CPAP, it pushes out those fluids out of the alveoli to make sure that it's still fully functioning. Okay. Question for the group: how is CPAP used to treat pulmonary edema? Well, pulmonary edema, just like the pneumonia, right? What happens is fluids start to build up, right? It starts to bunch up around the alveoli and go inside the alveoli. Well, why is that dangerous? Well, what happens in the alveoli, everybody? What's the important mechanism that happens in the alveoli? Gas exchange. Very good. So if there's fluids in there, gas exchange is not going to happen. What CPAP does is it pushes out the fluid out of that alveoli, so gas exchange can still take place. Does that answer your question? Okay, so moving on. Spontaneous pneumothorax. Spontaneous pneumothorax just basically means there's a weak part of the lung. That's called a bleb. Okay, so it's not because of a trauma. It just happens out of nowhere. That's why it's called spontaneous. It is very common for individuals that are very tall and skinny, right? Tall and skinny individuals usually get this. It could be genetics that is a result of this one. They can't really tell. But when your patients experience this, they're probably going to experience tachycardia. They're going to breathe really fast, and they're probably going to have cyanosis and very, very low O2 saturation if you do check it. Okay. CPAP is contraindicated for this type of patients because remember, there's positive air that's going into the lungs. Well, the lungs is already weak, right? So if you introduce more positive pressure in there, it's probably going to go through the thoracic cavity, right, to the pleural cavity. So air is going to go outside, okay, outside the lungs and causing more harm to the patients. So we're not going to give CPAP for somebody who has spontaneous pneumothorax, okay? Any questions so far for those types of diseases? Like I said, I'm just covering those highlights, okay? Because what's important on this specific chapters is not really diagnosing your patients, but more of identifying what is this condition. If you see a description, you'll be able to identify it right away, okay? But you're not required to diagnose. As long as you know the main treatment for these emergencies, you will be fine for it, okay? And then you have pulmonary embolism. Pulmonary embolism is just basically a clot from a blood clot, right, that traveled through the blood vessel that ended up in the lung. That's not a good sign because anytime there is an embolism or there's a clot, a blockage, oxygen is not going to be able to oxygen delivery or perfusion is not going to take place properly. Okay, so signs and symptoms of this one, patient's probably going to have some sharp chest pain and accompanied with shortness of breath. So almost the same thing as everything else, okay? Then we have epiglottitis. Epiglottitis is the most, out of all these diseases, it's the one that stands out because it's the only one that has a specific sound that happens? What is that sound of that you're going to hear when the patient has epiglottitis? Very good. Seal bark. Okay, it's that seal bark sound that you're going to hear. It used to be just with adults, but now it's very prevalent with children as well. Main thing for this one is keeping your patient calm, because you don't want the epiglottis to shut tight on the trachea. So you want to make sure that patient is as calm as they are, and you don't want to start inspecting the throat, because it might trigger and it might make things a lot worse. So that's why it says on page 481 under epiglottitis, this means you should not inspect the throat, because it's going to aggravate the condition of the epiglottitis. What can you do? If they're children, provide blow-by oxygen. That basically means putting a mask on top of the pediatric patient and not on the patient. Because remember, pediatric patients they do not like things on their faces, so they're just going to end up pulling the nasal cannula or the non-rebreather mask. So we're going to have to use the blow-by technique on that one. Then we have cystic fibrosis. Cystic fibrosis is a genetic disease. They still don't know what causes it. But it does tend, when a patient has cystic fibrosis, they tend to have thick, sticky mucus, right? That starts to build up in the lungs, it just starts developing. They cough large amounts of mucus. And when I say large amounts, it's not just like the phlegm that you have when you have a cold. We're talking about multiple high milliliters of mucus that the patient keeps on coughing. So that's for your cystic fibrosis, okay? And then the last one is the viral respiratory infections, basically cold. The patient has a flu, cold, or they have an itchy throat accompanied by sinusitis, right? Those are basically viral respiratory infections. We tend to get this during the flu season, which is September, October, November, December, right? During the cold seasons. Your patient's probably going to be complaining of that one. Question is, can we give NyQuil or any type of cold medications to our patients as EMT? Are we allowed to do that? Yes or no? No. That's a big no-no. Remember, you only have 7, right? You only have 7 things that you can assist and administer your patients. Most students pick the whole, oh, well, cold medications make sense. It's true, it does make sense, but it's not one of the 7 medications that you were taught. So make sure that you're not selecting those cold medications or any medications that are not part of what we talked about in chapter 16. Okay. So any questions about those conditions, class? Everybody good? Right. So let's talk about the prescribed inhaler. Main thing about the prescribed inhaler is, how am I going to administer the prescribed inhaler? Well, first off, what is the prescribed inhaler? First off, I have to verify my what? What do I need to verify for a prescribed inhaler? Very good. I see those 5 fingers right there. 5 rights. PRTMD, patient route time medication dose. I also need to verify that the medication is not expired. So proper steps. Okay, proper steps of administering this. Have the patient exhale or inhale first. What's the first thing that the patient needs to do? So you shake it, right? You tell them to. Very good. They need to exhale first. Push out all that air. It's basically clearing out the lungs. And then you're going to have them inhale as they depress the inhaler, and you're going to tell them to hold that as long as they can. Okay, and then after that, you're going to reassess your patient, and after 2 minutes, you're going to reassess them, ask them how they're doing. Some side effects of this one: increased pulse rate, a little bit of tremors and nervousness. The reason why the pulse rate increases is because one of the things that the bronchodilator does is it has that mechanism that opens up the bronchioles, right? And when the bronchioles open up way too much, that one of the things that the heart tends to do is work a little harder, okay? So it's going to increase that pulse rate right there. So that's why we do not just take inhalers if there's no signs of respiratory emergencies, because what can happen is you can have that increased pulse rate and nervousness, okay? So that is for your bronchodilator inhalers. Any questions with that, class? Okay, and then the last part of this one talks about the small volume nebulizer. Small volume nebulizer is basically, it allows the patient, the medication to be continuously delivered using an aerosol, right? And usually they're household contained, so the patient will probably have a small volume nebulizer, and they're gonna put the albuterol on there. Very common as well with pediatric patients. that have respiratory conditions that the parents already know. So your main job as an EMT is possibly just basically assisting with those types of small volume nebulizer. In nursing, you're going to learn how to set up one. Very, very easy. How to set up a small volume nebulizer. So it's the same exact way of how we do a bronchodilator inhaler. You have the patient exhale, okay, and then you have them inhale, take the air, hold it as long as they can, and then exhale as well, and then reassess after 2 minutes, okay? So that's basically your chapter 17. Any questions with that class? Everybody good with chapter 17? Okay. Anything I can clarify? Okay. Very good.
Someone.
Yes.
Well, we need to know about the aero chambers for the inhalers.
The what? I'm sorry.
The aero chambers for the inhalers.
Aero chambers for the inhalers.
Yes, it allows the better for people who aren't as coordinated as most people. The aero inhalers. I don't know if you can see my screen.
Oh, so it's talked about there a little bit in the textbook. The metered dose inhalers, okay, the MDIs or those. What do you call this? Too loud. Mute your microphones, please. It's not commonly used in a pre-hospital setting. But it is slowly being introduced there because some individuals, like you said, have a hard time following those simple instructions. So it meters those dosage that you give. So it's not generally described in the textbook. Okay, so it's just an FYI, quick information about it. Does that make sense? Okay. Right. Any more questions about chapter 17? Can you break down the definition of pulmonary embolism, a short description that you said earlier? Pulmonary embolism, like I said, it's a clot, right, that broke off from an occlusion or a thrombus, okay, and it traveled through the blood vessel and ended up into one of the blood vessels in the lung. Maybe it ended up in the pulmonary vein, maybe it ended up in the pulmonary artery, okay. It's basically a clot that broke off and ended up in the lung, causing that blockage. That makes sense? Okay. Any more questions? Right. Let's move on to cardiac emergencies. I'm not going to go over the. I'm not going to go over what do you call this? Go over the heart flow, the blood heart flow. You should already know this at this point. What's the proper flow of the blood, right? Starting from the superior vena cava, inferior vena cava, to the right atrium, through the tricuspid valve, to the right ventricle, to the pulmonary valve, to the pulmonary artery, to the lungs. Then it gets exchanged back to the pulmonary vein, to the left atrium, back to the mitral or bicuspid valve, through the left ventricle, through the aortic valve, through the aorta, then to the arteries, then the arterioles, then exchange in the capillaries, back to the venules and the veins, and then back to the superior and inferior vena cava. Right? You should already know that at this point. If you don't, let me know, and I'll start processing your paperwork back to Mod 1. Okay. So, acute coronary syndrome. Let's start with that specific term right there. Acute coronary syndrome is just basically a blanket term. Anytime that the heart does not receive the oxygen that it needs, that's called acute coronary syndrome. It's a lack of oxygen in the heart muscle, also known as cardiac compromise. What are the signs and symptoms of acute coronary syndrome? Well, the most common one is chest pain, right? Chest pain is the most common one associated with dyspnea, okay? Those are the most two common ones. Your patient might also have bradycardia or slow heart rate. They can also have tachycardia or fast heart rate. Okay, so that's your acute coronary syndrome. It's a very blanket term. Every time there's a lack of oxygen into the heart muscle. What can we do for acute coronary syndrome? Well, first we can consider oxygenation therapy depending on our patient's rate quality and O2 saturation as well. So one thing that I kept asking when I was teaching this lecture, it's your textbook specifically states that if the patient has a normal O2 saturation, sometimes there's no need to provide oxygen. However, my question to the class is, let's just say the patient has a 97% O2 saturation, but they're having signs and symptoms of respiratory distress. Are you going to give oxygen, or are you just going to continue on with your assessment? What do you do? Give oxygen or continue? Very good. You still give O2 because remember, you're relying on your patient. Ask your patient, hey, even though the number says 97% O2 saturation, it even said in your respiratory emergencies, regardless of the O2 saturation, if the patient complains of shortness of breath, I cannot breathe at all, you're still going to administer O2 for your patients, okay? Then you also want to consider giving your patients nitroglycerin. Nitroglycerin is a prescribed medication that basically dilates the coronary blood vessels, right? Coronary blood vessels. Going to page 498, okay? The indications for the nitroglycerin of 498. The patient must have chest pain, history of cardiac problems. It must be prescribed to them. Okay, the systolic blood pressure must be greater than 90, and it has to be authorized by the medical direction. Contraindications for this: if they have a BP that's lower than 90, a head injury, if they're infant or children, if they already took the maximum prescribed dose, which, oh, by the way, is 3. And then patient has recently taken erectile dysfunction medications, because again, erectile dysfunction medication is also a vasodilator. 2 vasodilators is a recipe for disaster. Your patient will go into shock. It's not a good day for your patient, okay? If your patient did take erectile dysfunction medications, you have to wait how many hours? How many hours do you have to wait before you can give nitroglycerin? Very good, very good, very good, very good. 48 to 72 hours, okay? 48 to 72 hours you have to wait before you give your patient a nitroglycerin to be fully flushed out of the system, okay? So how do we administer nitroglycerin? Same thing, verify 5 rights, PRTMD, verify expiration date, give the patient the pill, have them lift their tongue, put it underneath the tongue because it's sublingual, and then tell them not to chew, not to swallow, and then you reassess after 2 minutes, just like every medication. Okay, and then after that, side effects that you might see, hypotension, which makes sense because the blood vessels dilate, so the blood pressure does go down, and their pulse rate is going to probably change a little bit, might go up a little bit, because when the blood vessels open up, the heart is thinking, oh my gosh, my body's going to shock, so I have to beat faster. So the pulse might change a little bit, okay? So those are for your nitroglycerin. Another thing that you can give for your patients that have acute coronary syndrome is aspirin. Main thing about aspirin is it's chewable, and it's baby or children's aspirin because we don't have water in the back of the ambulance. So it's something we have to have something that can be easily taken by the patient. So aspirin here is utilized for as a blood thinning, not for pain specifically. So indications for this: patient must complain of chest pain. They must not be allergic to aspirin and no history of asthma. And why is that? Because majority of the times, if they have history of asthma, they can also be allergic to aspirin. They should not be taking any types of any anti-clotting or blood thinning medications, because it's going to be dangerous for your patient. If they accidentally bleed out, their body's going to have a hard time clotting naturally. And also they have to be able to swallow, and medical direction has to authorize the medication as well. Okay, so contraindications of that one, everything that I just mentioned, the opposite of that one. Those are going to be your contraindications of your aspirin. So how do you give that? Same thing. Expiration date, 5 rights if you have to. Okay, and also make sure that you're going to give it to your patient that is alert, and this time you can ask your patient to chew it and swallow it. Okay, so it's the opposite of nitroglycerin. Okay, and the actions of this one: it prevents blood clotting, and the side effects is nausea, vomiting, and possibly bleeding, because again, it's a blood thinner. So that's why that is the side effect of the aspirin. Okay. So any questions with those acute coronary syndrome, nitroglycerin, and aspirin? Question for the class: can I give nitroglycerin and aspirin at the same scenario? Let's just say I gave nitro didn't work. Can I give aspirin? Yes, you can, right? There's nothing that's stopping you from giving that as long as medical direction authorizes it, okay? Yes, you are exactly correct. It has to be granted by medical direction, right? So let's briefly talk about the causes of cardiac conditions. Coronary artery disease. Okay, so coronary artery disease. I'm going to do a quick share screen on this one. So I can draw it on the whiteboard. Okay, so for the coronary artery disease, let me see, how can I draw? Okay, so this is your blood vessel. Forgive me if it's not Picasso material, right? So occlusion is a full blockage, right? Occlusion is a full blockage. Coronary artery disease is anything that's blocking the arteries of the heart, hence coronary arteries. Occlusion is a full blockage. Thrombus is something that's, it could be fatty deposit or clots that are just attached to the arterial walls, right? So that can be a thrombus right there. Emboli, okay, emboli is something that could possibly, it's something that broke off from the occlusion or from the thrombus. And this emboli right here can be different sizes, right? And this is the one that travels through the blood vessels and that gets carried away. So that's why our patient can possibly get pulmonary embolism because of this. It could have probably started with right here. Somebody who has a coronary artery disease and that embolism from their coronary artery traveled and got pushed out to the rest of the body, and that's why it ended up to the lungs. So that's the difference between occlusion. Okay, so this is your occlusion right here, and then this is your thrombus and your embolism. Does that make sense, everybody? Okay, stopping the screen share. Okay, will a thrombus turn into occlusion if not dealt with? Yes, that is a possibility. Thrombus can definitely turn into occlusion if it's not dealt with, right? The book talked about real quick about the balloon catheterization. That is something that is outside your level. It was already discussed in class, but that's why you want to transport your patient right away because you want them to qualify for that specific treatment, which is the balloon catheterization, okay? So that's the difference between coronary thrombus, occlusion, and embolism. Aneurysm, simply put, is weakening of the arteries. Okay, that's when it's dilating, specifically the aorta, as you've learned in your abdominal emergencies, right? The abdominal aortic aneurysm. That is, and most of the time, this is for your patients that have trauma or the older patients as well. They're the ones that get aneurysm. Electrical malfunctions, these are the dysrhythmias. So when the heart is not beating properly, every time it's beating way too slow or way too fast, that is called dysrhythmia. Okay, and this can also mean ventricular fibrillation, ventricular tachycardia. Those are the ones that are shockable, right? Then we have pulseless electrical activity and asystole. Those are the ones that are non-shockable, and we'll talk about that more here shortly. And then we also have mechanical malfunctions of the heart. So basically, something's wrong with the artery, something wrong with the ventricle, something wrong with an atrium, so they have to undergo surgery. So that's basically a mechanical function. When something in the heart is not working properly, that's a mechanical malfunction. Okay, any questions so far? Okay, and then we have angina pectoris. Angina pectoris, simply put, chest pain. That's angina pectoris. When there's a lack of oxygen into the heart muscle, patient starts experiencing chest pain. So we call that in the medical field as angina pectoris. How do we treat that? Well, we already talked about that. Nitroglycerin or aspirin are the two medications that we can do to help alleviate the pain of the chest pain. Then we have acute myocardial infarction. Okay, acute myocardial infarction is basically the medical term for heart attack. Okay, that is when a portion of the heart muscle dies because of lack of oxygen. That is called an acute myocardial infarction. Okay. Sudden death is a term when there's a cardiac arrest that occurs within 2 hours of the onset of symptoms. So for example, your patient is experiencing chest pain and then all of a sudden they stop breathing. There's the heart starting to have ventricular tachycardia and ventricular fibrillation. That's called that sudden death right there within the first 2 hours. Okay, it's just basically a medical term that that we label the patient when there is a cardiac arrest within the first 2 hours. And then we have congestive heart failure. As I mentioned earlier from chapter 17, this is when the patient experiences fluid backup, right? Because the left ventricle is failing big time, right? The fluid is backing up, okay? And if you trace that fluid backup, it goes all the way back to the lungs, and then it goes all the way back to the body, right? And then you can see it on the neck veins can be distending. We call it jugular vein distension. The feet can be swollen, pulmonary edema. The back can be swollen, sacral edema, right? So those are just things that can start to happen when your patient does have congestive heart failure. Why is this important? Because when you're doing a focused physical exam and your patient did say that on their past medical history, I was diagnosed with congestive heart failure, one of the things that I would do if I was the EMT, I would start assessing for possible ankle edema or sacral edema on my patient just to see if, it is the congestive heart failure that's causing this cardiac emergency. Okay. So any questions with that class, with those different types of cardiac conditions? Okay, everybody good? Thumbs up if we're good. Wonderful, wonderful. Now let's talk about cardiac arrest, okay? Not gonna go too much in depth into this one because it's a review of BLS. So I'm just gonna touch on certain key points on this one. There's 5 chains of survival. What is the most important one on that chain of survival? What is the most important chain?
Rapid defibrillation.
Very good, very good, very good, very good. It's rapid defibrillation, okay? Early defibrillation, as per your textbook on page 508, early defibrillation is the single most important factor in determining survival from cardiac arrest. This is why during your cardiac arrest management, the CAM AED lab, sir, are you okay? No response, checking for breathing, patient's not breathing, no pulse, you call 911 and grab the AED because defibrillation needs to happen right away if I want my patient's survival rate to increase. So rapid defib is the most important out of all those 5 chains of survival, okay? When it comes to CPR, we have to provide effective CPR. You already know the depth for an adult and the compression rate for an adult as well as infants, right? 1 respiratory adult and 2 respiratory adult, it's 30:2, at least 2 inches, 100 to 120 compressions per minute. Children and infant, 1 respiratory, 30:2. Children and an infant, 2 respiratory, 15:2. Okay? And for children, it's at least 2 inches. For infant, it's approximately 1.5 inches. And how will I know if I'm giving effective breaths? How will I know if I'm giving effective breath? Very good. Visual rise and fall of the chest, not the stomach. Okay. A lot of you think that, oh, well, infants are stomach breathers, so I have to see their stomach rise. No, that's incorrect. That means you're incorrectly doing that specific breathing. Okay. Then the specific chapter also talked about automated external defibrillators, okay? It talked about specifically 2 types, shockable rhythms and non-shockable rhythms. Please know those 4 rhythms right there. What is shockable, what is not shockable? Page 512, ventricular fibrillation and ventricular tachycardia are shockable rhythms. PEA, pulse electrical activity, in asystole are the ones that are not shockable. This is why when you're attached to AED pads and it says, don't touch patient, analyzing, right? That's basically looking for a shockable rhythm, which is either VFib or VTEC, okay? So, any questions so far with this class? Right, let's go to page 514. Everybody flip your books to page 514. This is one thing that I want to cover that everybody knows, and I'm pretty sure this was covered as well in class. The main thing that I do want to talk about here is in page 514. It says right there, you already know the proper protocol when what's going on with your patient, right? Compressions, breaths, after 5 cycles, the AED analyzes, and it's going to tell me to shock or not shock. Question is, when do I transport the patient? You will transport your patient after 3 shocks has been delivered, as it said in your textbook, and also if you receive 3 consecutive no shock indicated. Okay, so let me say that again. 3 shocks has been delivered. It doesn't have to be consecutive, just 3 shocks, or 3 consecutive no shock indicated. That's the time that you're going to start transporting your patient immediately. Does that make sense, everybody? Okay, everybody clear on that one, class? So that's the main thing that I want to cover on that specific table right there. When's the right time to transport your patient, okay? And then moving on, we're going to skip that pictures right there because you already know how to operate an AED. I'm very confident that you guys know how to utilize that. I want to talk about page 518 though, okay, 518. Bystanders, okay? When it comes to bystander doing CPR, you're only going to stop the CPR and take over if it's ineffective. That means you can see that the bystander doesn't know what the heck they're doing. okay, they don't know, they're like not giving effective compressions, they're doing it all wrong, then you might want to take over, reassess the pulse. Maybe they did do something right, and then take over. However, if the bystander is doing everything correctly, they're BLS certified, their compressions are good, they're breathing, they're providing breaths adequately, do we have to stop the bystander if they're doing everything correctly? No, right? You don't have to stop them. All you have to do is say, hey, good job, keep on going. Remember 30:2, right? That's the main thing that we have to do, and that's specifically specified on that notes section on page 518, okay? Then we already know this, the special considerations for AED, okay? We're not going to use we cannot use the AED if we don't wipe the patient's chest, right? We have to quickly wipe it so that it doesn't travel through water. Move them out of the metal, or if they're touching metal, move them out of that scenario. If they're hairy, make sure that you either shave it or do that quick waxing, free waxing for your patients. And also, when your partner arrives with the AED, what's the new guideline state? When your partner arrives with the AED, before you start applying that AED, what do you have to verify first? Very good. Verify pulse, right? Effective pulse first. Verify it to make sure that maybe the compression's good. Okay? Maybe the compression to ventilation started working already. Okay? Please mute your mic, mute your mic, mute your mic, mute your mic.
Right? And I was going to say what's up to Wild Drop. So the door was cracked open. And I was
Jesus
like,
Christ.
"Oh,
You can tell who's
I
talking.
kicked it open. And
Hernandez,
in the thing, they kicked it open and I hit him in the head. And I was like, oh man, like, I'm sorry. I didn't,
Jesus fucking Christ, Hernandez. All right. Moving on. Thanks for that interruption, Hernandez. Make sure you guys call them out, please. All right. Also, when the patient has LVADs, right, the left ventricular assisted device, or implants, or anything on the chest, we can still put it, you just don't put it over it, you put it right beside it, okay? So those are the ones that we, for the AEDs. And then we also have the mechanical CPR devices. We have Lucas CPR device and the AutoPulse. Those are just basically mechanical devices that helps in assisting with our patients, right, to give effective compressions. They're slowly being introduced into the EMS system because of their accuracy. Okay? And the last part of this section, page 527, talks about when to terminate resuscitation, right? You're going to stop CPR when the patient's pulse comes back, right? When they start breathing, when another rescuer takes over for you, right? When you're too exhausted to continue, or when ALS already comes in and replaces you. That's the only time that you're going to terminate resuscitation. Okay? So, any questions with cardiac emergencies at all? Any questions? Everybody good? Right, so let's take quick 5, and then we'll finish off with 19. Okay, 9, 16, 17, 18, 19, 20. Okay, quick 5.